Zoll technology will guide you to meet the 2015 CPR guidelines. High-quality resuscitation on the move is achievable, and high perfusion CPR is within reach. When it comes to helping you deliver high-quality CPR, no one offers you more than Zoll.
Working in this department of the National University Hospital for the last 20 years, and as the years go by, it's become blatantly obvious that we're having more and more patients with cancer conditions crossing our threshold. And this is of course due to the vastly improving care that cancer specialists are able to offer their patients. But when these patients run into problems, and that is very frequently, they cross the threshold into our department and we have to look after them. And whilst medically we are trained to do all sorts of things for these patients, from a more holistic standpoint, sometimes communication is not very easy. And I say that because, and I guess I could be accused of being a bit critical of my colleagues upstairs, very often there's been little if any discussion between the oncology or cancer team with the families. And they have lots of questions and display a remarkable lack of information about their loved one's care.
Regularly in emergency department, and some of them are sudden, some of them are due to their chronic illnesses. There's a lot that we can do at ED.
And it's up to us to not only provide medical or nursing care, but also to an extent try to deal with some of the anxieties of the family and use terms that they can understand. And this is becoming a lot easier now because we're getting better at it. We've had to get reasonably good at it, and we will continue to improve.
And oftentimes we are not very familiar with what palliative care itself entails. So in order for us to overcome this barrier, I think educational activities, pathways, protocols have to be put in place. And the last barrier that sometimes is also quite difficult to overcome is within the hospital itself. Acceptance that ED is a place that can provide good palliative care for the patients. Decisions regarding end of life can be made in the emergent context of the emergency.
Alright, I think that should be right now.
Sorry, Dr.
Julia, yeah, sorry.
Yes, I have a question about a patient who has just come in.
Okay.
She's a 66-year-old lady who comes in for shortness of breath.
Okay.
On a background of metastatic breast cancer to the lung as well as the brain. So she comes in with saturations that are pretty low, 92%, and she's very tachypnic, quite a lot of distress. I've started some oxygen for her.
Good.
The chest X-ray which we just took shows a large pleural effusion on the left side actually. So I understand that in the emergency department we don't usually allow relatives to come in.
No, not normally, no.
Yeah, but in this situation, I'm just wondering whether we should actually let the family in, especially because previously it was discussed that we will not have any invasive measures such as CPR.
Family was keen for comfort measures only at that time.
Yeah, that's right.
Okay.
So
in this situation, we can make an exception. She looks like she's deteriorating. She may actually die soon.
That's right.
So I think it may be good that we allow the family to be with her in her final moments.
Okay.
Okay, so I think we can allow the family.
I'll bring them to somewhere private.
And have you given her anything for her discomfort?
Yeah, we've given something more eat.
Okay, that's fine.
Yeah.
Okay.
Okay, thank you.
Okay, why don't we go and speak to the family together?
Okay.
All right.
Relatives are very distraught, and many a time we just focus on the patient and we have neglected them. So I think for end-of-life care, we also must, while giving comfort to the patient, we also must take care of the relative.
It's very easy to fill up a patient with pain-killing medication. That's often required to alleviate their fears, their pains. But the other part of the problem with the family is the family. They need help. They need explanations that they can understand. And currently, we're not in the best of positions to do that. We're just learning. And so I give full support to the idea of palliative care in the emergency department. It's been a long time coming and it is certainly needed.
In any emergency, we often face stressful, overcrowding and busy situations in the resuscitation area. it is very difficult to provide good end-of-life care to the patients here. But I strongly believe that it's important to give to the patients and family members to see them through their difficult times.
I've been working in this department of the National University Hospital for the last 20 years. And as the years go by, it's become blatantly obvious